Oh, we're ready. Good morning and welcome to today's webinar, Autism Spectrum Disorder in the Primary Care Setting. This training today is being offered by the Behavioral Health Quality Department and medical directors. Today's training will be led by Chief Medical Officer Dr. Angela Momeka, along with behavioral health psychologists Dr. David Trejo and Dr. Elizabeth Fountain. If you have questions for the presenters, there will be time at the end of today's session for questions. Please type your questions in the question and answer box, and we will address them at the end of today's presentation. If you can go to the next slide, please. All right, there's just disclosures for today. All of our doctors are employed by Blue Cross and Blue Shield plans of Illinois, Montana, New Mexico, Oklahoma, and Texas. And I am going to turn this over now to Dr. Angela Momeka to get us started.
Hello. Okay, well, good morning. As Christy shared, I'm Dr. Angela Moameka, and it's a pleasure to present practical information about autism spectrum disorder in the primary care setting. Throughout the presentation, I will interchange autism spectrum disorder with ASD. You will also hear me refer to patients as people living with ASD or diagnosed with ASD. The presentation, next slide. The presentation will begin with tips for the primary care physician that you can apply in your practice today. Then we will dive into applied behavior analysis, and finally, we'll close with resources for patient-centered care. Go back to the previous slide. Thank you. ASD is a neurodevelopmental condition. And what that means, it's a difference in typical development caused by genetic, biological, environmental, or even unknown causes. People diagnosed with ASD may have delays in one, some, or all spheres of typical development. It is a lifelong condition, but can improve with age and with evidence-based and early interventions. ASD is not an intellectual disability. Next slide. Signs and symptoms of autism can be seen as early as 6 months of age, but usually by 3 years of age. Some children begin with typical development, then stop or regress after 18 to 24 months of age. There are 6 key features of ASD that are familiar to many primary care physicians. Atypical social communication and interaction skills, children who are unable to make or sustain eye contact, inability to show emotion through facial expressions, restrictive or repetitive behaviors and interests, following a specific set of routines and getting significantly agitated or distressed by minor changes. And finally, echolalia, which is repeating words or phrases over and over. Next slide. While ASD is not an intellectual disability or a physical disability, nor is it a mental health condition, it can be associated with all or some of these: language disorder, fine motor delays, intellectual disability, ADHD of all types, epilepsy, food aversions or restricted diet, and anxiety disorder. Next slide. The evidence around risk factors for ASD is still evolving. Thus far, these are the known risk factors: having a sibling with ASD, Fragile X syndrome, tuberous sclerosis, other genetic and chromosomal conditions, advanced parental age, and birth complications. Next slide. Similarly, researchers continue to better understand ASD prevalence. 2 studies published in the Journal of the American Medical Association, or JAMA, one in 2021 and the other in 2022, are displayed here. Both are based on National Health Interview Survey of 3 to 17-year-olds with a population size of 12,000 and 52,000, meant to give a representative sample of the general population. The findings are here. Prevalence in the first study was 24.9 or 25 per thousand, with a male to female ratio, male predominance 3.5 to 1. And in the second study, it was a prevalence of about 31 per thousand and a male to female ratio predominance with males of 3 to 1. Next slide. While we continue to better understand risk factors and prevalence of ASD, another evolution came in 2013 with DSM-5. The American Psychiatric Association's Diagnostic and Statistical Manual, 5th edition, combined all autism diagnoses into a single ASD diagnosis with 3 levels. The levels are based on severity of symptoms and how much support is needed in everyday life. Level 1 requires support, level 2 requires substantial support, and level 3 requires very substantial support. The diagnostic criteria in DSM-5 is as stated. A child must have persistent deficits in each of 3 areas of social communication and interaction, plus at least 2 of 4 types of restricted repetitive behaviors. Symptoms must be present in the early developmental period. Symptoms cause clinically significant impairment in social, occupational, or other important areas of current functioning. And finally, symptoms are not better explained by intellectual disability or global developmental delay. Next slide. We know that early intervention is critical for the prognosis of children with ASD. This is why early identification is necessary. This usually falls on the primary care physician who sees toddlers and preschoolers every 3 to 6 months from 12 months to 36 months. These are the peak identification years. There are several tools used in primary care and by diagnosticians. Some require user training, others can be completed by caregivers. Many are free, and there are those that are available for purchase. I'll share 4 tools with you today. First, let's talk about screening tools for low-risk children, so your general population. Across all of these tools, please remember that if there is a parental concern, it's important, in fact, imperative, to take that into consideration when deciding if a child needs further intervention or referral. The first tool is the one recommended by the American Academy of Pediatrics, Bright Futures, to use in screening all children during the 18-month and 24-month well-child visit. This is the modified checklist for autism in toddlers, revised with follow-up, or the MCHAT-RF. It is the most commonly used tool. If positive, you ask follow-up questions. If those questions lead you to persistent concerns, then you will refer to a diagnostician. Next slide. Next is the Survey of Well-Being of Young Children, Parents' Observations of Social Interaction. It's a mouthful. This survey includes 6 questions that focus purely on parental observations. It's a great way to complete a developmental screen and an autism screen in one tool. It does have low specificity, meaning a negative screen does not rule out ASD. Next slide. When it comes to high-risk children, we typically screen sooner since we have identified family or personal history that points to a possible diagnosis of ASD. One example of a tool for this population of children is Communication and Symbolic Scales Developmental Profile, Infant Toddler Checklist. This tool can be used as early as 6 months of age. A positive screen gives cause to refer the child for more specialized testing by a diagnostician. Next slide. The last tool that I'll mention, and this is really just for honorable mention and awareness, is the RITA, which is the Rapid Interactive Screening Test for Autism in Toddlers. Unlike the other tools, this one has to be purchased, and it does require user training to administer the tool. While the RITA can be used in a primary care setting, it will depend on practice workflow and available staff. A positive screen is diagnostic and requires referral to a specialist in ASD. Given the high sensitivity and high negative predictive value, a negative screen is reassuring. Next slide. Medical expertise is necessary for the screening and counseling required to identify symptoms concerning for ASD. Primary care physicians can bill for these services. I've listed the most common ICD-10 or diagnosis codes used for these visits. Encounter for screening for unspecified developmental delays, encounter for autism screening, which is often the common one to use, encounter for screening for global developmental delays, and then the final one is the encounter for screening for other developmental delays. The associated CPT or procedure code is the 96110 code. Next slide. Now let's pause and get really practical. What do you do when a child comes in for a well child visit and there are concerns for ASD, or it is an age to screen for ASD? Well, first, remember that ASD is often the unspoken worry of parents and caregivers. Additionally, the identification of possible ASD can be a life-changing event for families, even before there's a formal diagnosis. Here are some practical tips for family-centered care. Review and understand the screening tool that you're going to use, and understand the questions and scoring before using the tool. Train your staff so that they also understand this. Be clear about the intention of each question in the screening tool. For example, in the MChat, there's a question that looks for behaviors in some children with autism spectrum disorder. Phrase it in that way. This question is looking for behaviors seen in some children with autism spectrum disorder, or this tool is used to look for concerning behaviors that are seen in some children with autism spectrum disorder. One of those questions, does your child get upset by everyday noises? Give examples. Does your child scream or cry to noises like a vacuum cleaner or loud music? So there's no misunderstanding of typical versus atypical development and behavior. Listen when families voice concerns. I should underline and bold this. Listen when families voice concerns. Use family concerns as a guide when you're reviewing developmental screening results. Clarify the tool is only screening for signs and symptoms of autism. It is not a diagnosis. Be aware that testing by a developmental professional or diagnostician is needed to diagnose autism. Understand that the diagnosis of autism is a concern for most parents of toddlers, even if they don't voice that. It could be a minimal concern, but it's still there. And finally, let the family lead the conversation and support with facts, not opinions. We can go to the next slide. What do you do when the screening tool is positive? First, absolutely, first things first, refer to ECI or early childhood intervention. That is something you can do without a diagnosis of autism if there are concerns about atypical development. ECI offers longitudinal support from the moment of referral all the way to 36 months of age, when that child is then transitioned from ECI to the preschool program for children with disabilities. Refer this child to a developmental pediatrician, a pediatric neurologist, or psychologist for diagnostic testing. ABA providers or applied behavior analysis providers are great partners in identifying developmental providers or diagnosticians. Explain the process to the family because it can be a really stressful and long process. By age 2, a diagnosis can be considered reliable. Testing is usually either a 4-hour visit. For some diagnosticians, it's a full day visit. Results are discussed with the family a few weeks after the diagnostic testing, allowing time for that diagnostician to score the results and be able to have a full analysis. The time frame really depends on that provider or diagnostician. Results are typically sent to the family and to the referring physician. It's a multi-page document that includes patient history, presenting signs and symptoms, results of any screening tools, quantitative and qualitative scoring with tests with scoring, and interpretation, diagnoses, and recommendations. It's helpful to schedule a visit with the family to review recommendations and answer any of their questions, even if it's a televisit or a virtual visit. Typically, the developmental professional doesn't initiate referrals, but some do. So you want to confirm with that diagnostician before moving forward with referrals so there isn't any duplication. Next slide. After the visit with a diagnostician, families will be given a common set of recommendations. The following three are the most important referrals to initiate as soon as possible and can be initiated at the same time. The first is applied behavior analysis. A diagnosis of ASD is required for that referral. The second is medical therapy, so speech and occupational therapy. And the third is school services when the child is age appropriate. So a letter to special education office or department can be included with what is sent by the diagnostician, but if it's not, parents can request this letter. Assessment and letter can be submitted to the school district for child find evaluation or getting a child into special education. There are other recommendations that are typically included: family counseling, family support groups or advocacy groups, literature on ASD, um, other literature on comorbidities, hippotherapy, which is equine or horse therapy, and music therapy. I cannot overstate this. It is important that referrals are completed as soon as possible. Next slide. As children living with ASD transition from ECI to the school setting, and for your older patients diagnosed with ASD, understanding their education rights is critical to socialization and school success. School services address the needs of individuals with physical, medical, or cognitive conditions that affect learning. Now, there are two terms that often get misunderstood in the primary care setting or outside of the school setting. I'm going to go through each of them carefully. Section 504, where people hear a 504 plan, is Section 504 of the Rehabilitation Act of 1973. These are protections for individuals with disabilities in programs that receive federal funding, such as public schools. A 504 plan accommodates and supports access to academic and extracurricular activities. This plan is for students who do not require special education services. For instance, your child who has significant or concerning seizure disorder can have a 504 plan. Next slide. Students with ASD need a different plan. It's called an individualized education plan, and it is part of the Individuals with Disabilities Act of 2024, also known as the IDEA Act. It identifies students who need an IEP, students who require special education services, and IEPs provide for free and appropriate public education in the least restrictive environment for all children with disabilities. That second bullet point is a critical bullet point, and those words in parentheses are actually the core words that allows parents to be able to advocate for their child, and you as well, to ensure that they get the right services. An IEP outlines a program of specialized instruction and supports that allow children with ASD to access and progress in the curriculum. There are measurable learning goals, there are accommodations, and there should be a tracking of progress. It should also include related services. ABA, or Applied Behavior Analysis, can be provided in or out of school. Educate families that IDEA requires public schools to provide ABA therapy when indicated as a necessary service to help the child access or participate in schools. I will now hand off to Dr. Elizabeth Fountain to educate us on applied behavior analysis.
Good morning. Next slide, please. Thank you. So I just want to provide a high-level overview of what ABA or applied behavior analysis is and how it works to address the symptoms associated with the diagnosis of autism. In the behavioral health space, there are very few empirically supported treatments for the symptoms of autism. Many treatments are still considered experimental, investigational. Many individuals are, trying to come up with some promising research, but have not, gotten to that empirically validated stage. Also, some treatments that are being set forth at times are ineffective or can even be harmful. Unfortunately, families are often desperately seeking any type of service or support that can assist their child. And so it's really important that we are steering families towards those empirically validated treatments. Applied behavior analysis is a more intensive therapy. It uses procedures that are based on the science of learning and behavior to address skills deficits and address problem behaviors that may be a barrier to the individual being able to access the least restrictive setting. It is a fairly young science, and so many individuals aren't as familiar with how it operates or the details of how it's implemented. It got its start back in the 1960s, and it's really designed to teach new skills, to replace problem behaviors with more socially acceptable behavior, identifying the relationship between the individual's behavior and the environment. So we're wanting to teach new skills. We're wanting to teach new ways of getting wants and needs met. We're wanting to make sure that the individual is able to generalize the skills that they have to multiple different people, situations, environments, trying to reduce the conditions under which the person might resort to problem behavior to get their wants and needs met instead, and really help that person catch up to typically developing peers and remediate the developmental delays that they may be displaying. Next slide, please. So the ABA model of care, it is very intensive, more so than the typical outpatient therapy, and it is delivered in a tiered service delivery model, meaning that there's a team of therapists that are going to be implementing this treatment. And those therapists are typically at different education and experience levels. So the person who assesses the individual, designs the treatment plan, oversees the day-to-day therapy is typically a master's level board certified behavior analyst, or maybe at the doctoral level. And they are really the one who is providing that clinical expertise, oversight, supervision, case management of the individual's treatment plan. But the person who is directly delivering the therapy, it may be one or it may be a team of individuals. Those are typically registered behavior technicians, which is a credential, a national credential, does require some training and experience. But those are the individuals who are carrying out that treatment plan under the oversight of the master's or doctoral level therapist. Next slide, please. The intensity of the service can vary. Typically falls into one of two buckets, either a comprehensive program or a focused program. Comprehensive is very intense, 30 to 40 hours of direct treatment a week. So literally 8 hours a day, 5 days a week, like a full-time job. And that may be a little bit surprising, considering it is an outpatient service, but it's really designed to get at that early intervention. It's typically at that intensity for younger individuals, that under 5 age group, but it can be useful at that intensity up to about age 8. And what it's designed to do is address deficits across multiple different areas of development. So, communication skills, executive functioning, social skills, daily living skills. Individuals who have deficits across multiple different areas and really need that intensive treatment time to devote to helping them get caught up on a developmental to their chronological age. And what it does is it breaks down skills and goals across each of these domains, and then a significant amount of treatment time is devoted to teaching those skills and addressing those behaviors. The other intensity of service is referred to as a focused program, and that's less. It's usually about 10 to 20 hours a week. And typically, individuals who are receiving the less intensive amount of therapy may have fewer deficits. Typically, they are older. They may have received several years of treatment previously and kind of stepping down to that more focused program. Um, prioritizes the most necessary functional skills, and again, it is more common in older individuals, age 8 and over. The location where ABA treatment takes place, conventionally, it's typically in a clinic, like an outpatient clinic, where everyone who is there is receiving ABA. But there's also home-based services available as well, where the therapist will travel to the individual's home and deliver the therapy to them right there in their home with their family and caregivers. But typically, that is the preferred location for ABA, given that the therapist has the ability to control the environment to a reasonable degree and can really systematically target the skills that the individual needs to work on in their treatment plan. However, often people may receive ABA in other locations as well. We kind of refer to that as a non-conventional treatment location. And that's where maybe an individual who is accessing school could be receiving some ABA as part of their IEP to assist with accessing, participating in education. Other settings might include vocational training programs. They may employ a BCBA to come in and design some treatment to help the individual acquire some job skills. Just a variety of other locations, recreational programs, day programs. ABA can be implemented across a variety of different settings. One of the important distinctions is to ensure that the treatment that's being delivered is really intensive therapy, where the therapist has identified a skills deficit and they are systematically teaching those skills through that intensive one-to-one therapy, as opposed to acting as a shadow or aid support or something that might be better described as like respite, where they're kind of shadowing the individual and assisting them to access the other program. If it's a service of that nature, that would not typically be defined as applied behavior analysis. They'd be using a lot of the strategies and techniques from ABA as that behavior aid or shadow. But what we're talking about today is specifically that intensive therapy to remediate deficits. Next slide, please. So here are some examples of what goals in an ABA program might look like. The purpose is to ensure that any goals that are written into a program are operationally defined in a very objectively measurable way, and that they are tied back to a specific skills deficit associated with the diagnosis of autism. So I'll just kind of run through these examples and talk through how they would assist the individual. So for example, working with John, he may have a problem behavior where when he's confronted with something that he can't do, instead of using functional communication to ask for help, he's falling to the ground, he's crying, he's having a tantrum, and then an adult or a caregiver comes over and helps him. So what therapy would be designed to help him to do would be to confront him with something that's difficult, something that he needs help with, and then prompt him to ask for help in an appropriate way, and then deliver that help, show him that he can access that need, get that need met with lots of praise and reinforcement. And through a lot of practice and repetition, John will learn when I can't do something, I need to ask for help instead of having this problem behavior. And then hopefully he will generalize that to multiple individuals and across multiple settings so that he can get his needs met without the problem behavior that could be disruptive and limit his ability to access multiple settings. Another example related to social skills. Amira has difficulty taking turns and sharing with peers when it's playtime. That can be a more unstructured situation. And so she may need the assistance of an adult to facilitate and show her how to take turns, how to relinquish a toy, how to request to have that toy back when it's her turn. Might use a timer to help her see how long her friend gets to have a turn with the preferred toy. And just to really facilitate that so that the child can access that social reinforcement of being included in play and being able to have that reciprocity with peers. And through, again, practice and repetition, she will learn that she can enjoy and be included in the group and be included in play if she follows these specific required behaviors for that situation. Carlos may have difficulty with more aspects of executive functioning, which is a multi-step process. If you're given directions to go to a specific location, get an object, bring it back, give it to this person, that requires receptive language, that requires planning, that requires chaining multiple steps together. And so that's a prerequisite skill that's really important for more complex daily living skills, things like being able to tell someone, go take a shower. Well, that has many steps involved in it of having to go turn the water on, check the temperature, make sure you have a towel, make sure you have soap, washing yourself in a specific sequence. And so this is a really important prerequisite skill for that executive functioning and development. And then lastly, an example for Kalani, who has difficulty with functional communication, with expressing wants and needs through making requests. While language deficits are not a required symptom for a diagnosis of autism, many individuals do have impairment in functional communication. And so consistently teaching them that these are the names of items. This is how to make a request. This is how to make a request in a sentence. And this is how to ask for a thing versus an activity or an action. And having them practice through multiple trials and repetition for them to then be reinforced by receiving that thing that they're asking for will teach them to use functional language to get their wants and needs met, and then be able to generalize that across multiple settings so they can use that with different people, caregivers, peers, in school, at jobs, at camps, in a variety of different locations to increase their overall functioning. Next slide. For this, I'm going to hand off to Dr. David Trejo so he can talk about the scientific research that supports ABA.
Good morning. Yeah, that is exactly the area that I want to discuss. So the beginning points and end points of the treatment and the research associated with it. As we know, you're required to consult the literature first. Is there science behind that before making a clinical recommendation? Typical medical necessity definitions often mean that it's based on the supporting science behind a treatment, the efficacy of it, and not for other concerns like convenience or preference or financial gain, of course, of the provider. So as Dr. Fountain mentioned, ABA got its start in 1968, but was not applied to this condition until 1987 in the original study by Ivar Lovas. And kind of want to look at exactly what that study did and what were the parameters around that study and follow-up work on it as well. So next slide, please. Now, in 1987, we looked at a study with 38 children, all between the ages of 2 and 4 years of age. So during that time, 2 years of intervention, there was an experimental group that received 40 hours of treatment, and there was a control group that received 10 hours of treatment, and another control group that received treatment as usual, regular interventions, school-based treatments, or the like. Let's go to the next slide, talk about results. Of those 19 in the experimental group, 9 achieved average IQ and no longer met the criteria for autism diagnosis. There's been some terms used, recovered, cured. It's been replaced in recent meta-analysis and lit reviews as optimal outcome. But a portion of those participants did achieve that optimal outcome. You'll often wonder why possibly every carrier in the U.S. Asks for an updated diagnosis between 2 and 3 years. This is precisely where that's coming from. This is, indicating that as the empirical support for this treatment is the best treatment we have for autism currently, indicating about that 48% or so did receive that optimal outcome. There were some that made some gains but did not remediate all the symptoms, so they had some improvement, and then two did not benefit from treatment at all within that experimental group. So they received 40 hours per week for 2 years, but didn't benefit from ABA at all. Next slide, please. Now, there were a couple of concerns with the original study that folks quickly pointed out. They said you have cherry picked the patients in that group, the experimental group, to have the highest IQ. So a replication was done, 2 years of study, and was not randomized. It was counterbalanced based on IQ, but found the same results. About half of those children met that optimal outcome. Later studies and other folks said, well, 2 years is not enough. What if we did 3 years? 3 years found the same results, the same. About half of those participants reached that optimal outcome. Here's my little claim to fame in the literature. 4 years of treatment. I was involved in the study, was a technician on that study in graduate school, where we had to turn in our data sheets to to the center for that study. So 2 years, 2 years, 3 years, and 4 years. 4 years did not find different results either than the 2 year studies as well. In the literature, they say 3 years is the average treatment duration, and that comes from 2 years plus 2 years plus 3 years plus 4 years, 2.75. It's about 3 years of treatment. So at that time, often an updated diagnosis: is this still warranted? Is this treatment effective? Should this be continued on? Should this be at a focused level now? Now, if you start treatment between the ages of 2 and 4, by the time you're getting close to that 8 years of age, that is usually when that treatment begins to taper off and begin to become a focused program, prioritizing the skills that will make their life better and their families' lives easier. Oftentimes, that's communication and activities of daily living and problem behavior. And that is done at a smaller treatment intensity as they begin to prepare for bigger life questions. Now, research in the real world. So TRICARE is the largest insurance carrier in the world. Did a 10-year autism demonstration project, hotly controversial in that they found ABA had limited effectiveness. So it's still being debated now. They testified before Congress on the results of it. And the provider community, as a response to that, said, we don't like the outcome measures that you're using, so we're going to choose our own outcome measures. We don't like the PDBI, for example, including the author of the PDBI testified on how it was utilized in the study. They said, we're going to submit our own data to a repository over the next several years, and we're going to choose the assessments that we feel are those indicators of progress that will show good or bad, outcomes. Although they did acknowledge criterion referenced assessments such as the VB map or ABLS, they went with Vineland 3 and SRS-2. SRS-2 is a social skills only. Vineland is an adaptive behavior skills assessment as well. And they're using those assessment tools now to show the efficacy of the treatment in the real world. The other studies that I mentioned in the past are university-based, where you have a higher degree of oversight, you have unlimited staffing, people's grades dependent on this. I know when I was in graduate school, we taught a laboratory section of an applied behavior analysis course, and the undergraduates worked at an ABA provider, and their grade was tied to this. So you have less attrition than you do in kind of real world settings. So hopefully that yields some better results, and we kind of see more clearly kind of a real world application of the intervention. Other endpoints to consider, you have your assessment scores, you have your goal mastery. Goal mastery is a little bit difficult to gauge because you could have a goal that is broken down into 26 steps to tie shoes, or it could be 5 steps to tie shoes. It's difficult to pit one goal versus another goal versus one treatment plan versus a highly individualized treatment plan for another patient. So you need multiple measures. For example, you need to have your assessment scores. You can also have goal mastery, and then you can look at problem behavior. Was problem behavior reduced? There's essentially, I guess, a couple of outcomes that could occur with problem behavior that's dangerous to self or others. You can have a great reduction so that it's reduced significantly, and they could have access to a lower intensity of care. Or it could be the other side of the coin where problem behavior did not get better or got worse with treatment. The treatment is making the problem behavior worse as a result. Um, then you can have a problem behavior that remains stable across time. There's no effect of the intervention. All three of which are kind of taken into consideration with that outcome data, that progress. Is the patient benefiting from this care? After 3 years of intensive treatment, that 49, 50 hours, 40 of direct, and then your supervision hours as well. If things don't look like they've improved, then they might not be in that optimal outcome sort of camp, so to speak, of that area. And then you need to evaluate what other community-based supports are available or what other services might be more appropriate at that time. A lack of progress is written within to our ethical code as a reason for discharge. We should not continue to apply a treatment that's been shown to be ineffective for several months and years at a time. But it's one of those considerations that you have to plan for, kind of, okay, this didn't work, but what are we going to do next? What are we going to do now? Where are they going to go? And often you can work with, social worker components of your carrier or others to find programs and supports in the community for the individual. Next slide, please. And then I think we're going to go back to patient-centered care with Dr. Momeka.
All right. I don't know about you, but I learned quite a bit in that section. Thank you, Dr. Trejo and Dr. Fountain. As I mentioned earlier, family-centered care is the key. For children, person-centered care is family-centered care. So even though you see patient-centered care here, you're going to see things that really involve the entire family. First of all, the medical home is the hub for the care plan and should be the hub for the care plan, the place that families can go to understand all the resources and all the steps around diagnosis and management for their child living with ASD. Families should receive referrals necessary to access their various therapies and services. Referrals should be updated periodically to make sure that they truly do match what the child needs at that stage. If there is medication management involving a psychiatrist or neurologist with experience working with individuals living with ASD is a critical step. Many services will have wait lists, so encourage families to sign up even if they are unsure if the service will be needed. Because again, over the course of time, you may find that the child will need these services. They can always decline should it not be needed when it's their turn. Case management and service coordination can be available through their insurance plan or the county local intellectual or developmental disabilities authority, or LIDA. Clinical best practice includes periodic reevaluation during well-child visits, during regularly scheduled visits, to really meet with the family to discuss any concerns and any changes and what to anticipate in the future. Every 2 to 3 years is typical in addition to well-child visits, and this ensures awareness of current symptoms, changing needs, and screening for any comorbid conditions. We'll go to the next slide. Caring for children with autism and children who have been diagnosed with autism means anticipating their needs as they grow, while supporting their families and caregivers through all of these changes. In the early period, during the early intervention years, it's initiation of those therapies, it's looking at feeding, it's looking at toileting and toilet training, and the appropriate ways and supports to facilitate these processes. In the school age years, it's educational supports, specifically the IEP, but for some children, they may not need an IEP and they really may need a 504 plan instead. It really depends on the child, the recommendations from the diagnostician, and the family's preferences. Behavioral supports are going to be important during school age. So this includes applied behavior therapy, um, applied behavior analysis. Social skills programs, especially peer programs and support groups, are helpful, and life skills training. In the adolescent period, remember that you have a child who has a neurodevelopmental condition who is not developing typically, but physically is developing typically. So, puberty is something that really should be anticipated and discussed not just with that child, but also with the family and caregivers. Talking about healthy sexuality and body image, safe internet use, and again, building up life skills for that appropriate age. And then finally, in the adult stage, you're looking at transitional programs and vocational supports, specialized university programs for individuals living with ASD, day programs if necessary, and then also integrated community-based settings such as housing choice as that child matures and wants to live as an adult independently. Next slide. There are resources the primary care physician should be aware of when caring for individuals living with ASD. Familiarizing yourselves with these resources will better prepare you to support your patients and their families. Autism Speaks has a resource guide that includes not only resources for families, but also for physicians caring for individuals living with autism, including services that will support that individual and the family. There are Medicaid waiver programs, which are different by state, but there are programs for individuals who have developmental disabilities. And those programs are typically programs that you have to apply for ahead of time and tend to have long wait lists. State-specific resources, just as examples, the Illinois Department of Human Services, the Division of Developmental Disabilities has resources available that are state-specific. The Texas Department of Aging and Disability Services has listing of the LIDAs, or local intellectual and developmental disability authorities in the state. Early Childhood Intervention website will have state-specific forms, referral sources, and pointers in terms of what to do when you're referring a child into ECI. Again, in Texas, there are community resource coordination groups known as CRCGs. There are similar groups in other states. What these groups do is they bring together families and community-based organizations along with state agencies, and you essentially discuss the family member, the child, the adult, and you have these resources that are wraparound resources that help to solution whatever the issue might be and plug you into the resources that are needed. And then finally, there are online resources like Navigate Life Texas that are really focused on individuals living with disabilities and their family and support systems. The websites like Navigate Life Texas, I highly recommend, because what they do is they create not just an online community that's a safe community, but they take away from a lot of the disinformation and misinformation that might be existing within that state. And they also connect families to each other so that they can be supports for each other as they go through the stages of a child living with autism. Other local resources include Autism Resource Centers, Easter Seals, and Special Olympics. Again, the intention of our presentation is to share practical tips on ASD that you can put into practice today. It has been a delight speaking with you all today. I will now hand this back to Christy. Thank you.
Wonderful. Thank you, Dr. Momeka, Dr. Trejo, and Dr. Fountain. Really appreciate all the wonderful information you shared today. We are going to open up for question and answer right now, but I do just want to make a quick note. I know some had technical issues today. This webinar is being recorded. The webinar recording and link to the CME CEU will be available 24 hours after today's recording. Will be at the same site that you registered and can be found under the courses tab. Also, if you want a copy of the slide deck after today's presentation, you can download a copy at that same site where you'll be completing your evaluation attestation for the CME CEU. Quite a few questions in the chat, so I just want to get into them in the time that we have left. And so Dr. Momeka, Dr. Trejo, Dr. Fountain, whoever wants to take these, I will just put them out there. So the first question, are there any specific screening tools for older children?
So I can take that. And I'll also open it up to Dr. Fountain and Dr. Trejo. But screening tools are really looking to identify as early as possible a child who might have autism spectrum disorder. If you have an older child where you have concerns, so outside of that, 6 months to 36-month period, and there is a concern that that child has features that appear to be ASD features, the appropriate step is to refer that child to a diagnostician because you don't want to delay in any way. If there is a concern at an older age, you want to get that child diagnosed, you want to get that done as quickly as possible so you can begin to plug that child into resources or that adolescent or adult.
Great, thank you, Dr. Momeka. And I did see a couple questions in there. For clients who experience symptoms as adults but have been perhaps masking for decades, are there resources that can be provided for adults with autism spectrum?
Yes. So all of the resources on this resource page are for all ages outside of early childhood intervention. But even, I'll say this, even ECI can be a support in terms of plugging you into state-specific resources that you may not be familiar with because they're working with these organizations all the time. Um, what I would recommend is certainly understanding what your state offers in terms of autism resources. And the best way to do that is to plug into your state's health department, Department of Health and Social Services. But that's your first step, is really to plug in there and understand what is state specific and what's offered, and then go from there. Autism Speaks is national and a useful resource and a good way as well to understand what's available, what is there nationally, what are some literature that you can share with families, etc. But you want to make sure that no matter what your source is, that you are really working alongside the family to make sure that they want these resources and that they're ready to absorb it. So it's a step-by-step process. And I'll give you an example. So I'm a general pediatrician, and in my practice, I mainly saw children who had physical or intellectual and developmental disabilities. So it was probably about 60% of my practice. So quite a few of my patients were children and adolescents living with ASD. A family came in, there was a new family, and mom came in for a 13-year well child visit with her son. Well, in meeting with that child one-on-one, what I noticed was his communication style was very stereotyped, and there was what could have been interpreted as echolalia. What I could have done is say, oh my gosh, this is a child with ASD. We need to refer him right away. Let's go, let's go, let's go. We don't want to miss. He's 13 already. What have we missed? What was most helpful to the mother, however, was bringing her back into the room and asking her about his developmental history, talking to her about what others have already said or recommended for this child, and also including not being afraid to say, this is my concern. Doesn't mean it's what's happening, but here's my concern, and this is why I'm concerned. So you want to certainly begin with that very family-centered approach of where are you now? How ready are you for this diagnosis and for this management? And then from there, go into here are some resources for you.
Thank you, Dr. Momeka. The other question I see here, and we'll try our best to get to all of them, but we may not have the time. The next question, would a high functioning youth with ASD need an IEP or can they have a 504 plan?
That's a great question, and I'm glad you asked that question. So it means I made my goal was to make sure to separate the two in people's minds. But it really depends. It really depends on two things. One, your assessment of that child and the diagnostician's diagnosis of the child or adolescent, and then also it depends on what the family wants. There are families who do not want their child in special education. It is a parental choice. So those are the two things you really want to look at. The 504 plan simply allows accommodations for academics and for extracurricular activities. It will not place a child into special education. The IEP is really related to IDEA Act and making sure a child who's eligible for special education is placed in special education. I would say if you have a child, high functioning or not, an adolescent functioning or not, or whether they're level one, level two, in terms of their ASD level, that your first step before anything else is to look at an IEP. Because the IEP, if you want to look at it this way, is actually the higher level or will give them more resources than what a 504 plan will give. During that assessment for the IEP, if the school then says, you know what, after assessing, after looking at the resource, the recommendations from the diagnostician, we are not convinced that this child needs or requires special education services, then that's a conversation, right, to have with the diagnostician, with the family, and also with that individual if they are old enough to and able to join in that conversation of what the next steps are. So there's no one kind of one size fits all approach to IEP versus 504 plan. It really depends on the child and family.
Thank you, Dr. Momeka. Um, so, would you recommend psychological or neuropsychological testing for diagnostic clarification in more complex cases?
So, in terms of what I recommend, I'll put it this way. What I recommend is if you have a child that you're concerned about ASD, complex or not, your first step is to refer them to a diagnostician. And that diagnostician, as part of their recommendations, would then include this is someone who should get neuropsychological testing. This is someone who should get, right? That's what you want to make sure of. And this is the reason why it's important to make sure it is a diagnostician who makes the diagnosis, because you have children who, for all intents and purposes, appear to have or be individuals living with ASD, but they have a different developmental disorder that's a pervasive developmental disorder or a social skills disorder, or they have additional complications and comorbidities that are not identifiable with the screening tools that we use in primary care. So that referral to diagnostician is very important as a first step.
Um, and then, what about for children with ASD to have ABA therapy and rehab therapy at the same time? Could it be too much for the child?
Well, I'm going to have Dr. Fountain or Dr. Trejo feel that from the ABA perspective, and then I can always jump in.
Sure, I can address that. A lot of times these therapies will work in collaboration with one another. An individual could be receiving speech, OT, physical therapy, horseback riding therapy, a variety of different modalities, but they're all designed at addressing these developmental delays, the spectrum of which we see associated with the diagnosis. And so one of the standards of care is for the therapists to collaborate with one another, to share strategies that are working, to ensure that they're not implementing interventions that could be working against one another. And so typically, like for example, if a child is receiving 40 hours a week of ABA at an outpatient ABA clinic, their speech therapist may be co-located or may travel to the clinic where they will pause their ABA therapy for 30 minutes to an hour to go get their speech therapy or their OT. Their OT may be giving recommendations to their ABA therapist and saying, hey, these are aspects of the sensory diet that's really beneficial to this child. Please incorporate them in your ABA therapy session so that they can get those sensory needs met. So really, what you want to ensure and try to promote is collaboration of all of these different therapies working together. I do often hear concerns that, especially for the younger kids, in kindergarten and first grade, that it can be a really long day if they're getting up, they're going to school, they're coming home from school, they're getting therapy all afternoon. It's like the child is engaged in some kind of structured activity for every waking moment of their day. And so that I think it really takes knowing the individual child's limits and needs, giving them the breaks that they need, and working collaboratively with all of the different entities that are supporting the child to ensure that everyone's working together to make sure that they're not just completely exhausted, because that is a very, very valid concern. But to collaboratively figure out the best plan for that child. And it can be a balancing act. That's very true.
Thanks,
Yeah,
Dr.
absolutely agree. There's another question in there regarding prioritizing ABA versus speech and OT when the primary deficits are in speech. Applied behavior analysts aren't speech therapists, and many of licensure laws, say for example in Illinois, explicitly state that a behavior analyst cannot practice speech therapy. There is a little bit of overlap, but they're expressly forbidden essentially from practicing in those areas. It's beyond their scope of control. They do not receive training in articulation, for example. Like, should you be working on that if you're not don't have the education, training, or experience in that area? You should refer out and work collaboratively with these other professionals that are trained in that area that can work with those disorders. And as Dr. Fountain mentioned, can work hand in hand, and that's why it's a growing trend to see multi-specialty clinics that have a speech therapist, an occupational therapist, and ABA all in one place. Hopefully that's a continued trend and they can get all the services they need. And yes, ABA is so intensive, 40 hours per week oftentimes doesn't leave much. So there becomes that kind of push and pull of what are they going to do? And you run into this, especially when you have, 2 and 3 year old kids that are just, falling asleep during session, like, okay, we've hit a wall. There's only so much we can do in the day. But yeah, that's definitely something that has to be explored.
Thank you, Dr. Fountain and Dr. Trejo. We are at the top of the hour, and I'm sorry we could not get to all of the questions, but I just want to thank our presenters and all of our attendees and great questions that were put out there today. As a reminder, today's webinar was recorded. The webinar recording and a copy of the slide deck for you to download will be available on the website that you registered for this training at. It will be available after 24 hours from today's webinar at that same site. You can go on there. You will have access to the link to, you need to complete an attestation and an evaluation of today's training in order to receive your CME and CEU certificate. So you'll receive that email link to complete the evaluation and attestation for today's CEU training after 24 hours from this webinar. And just thank you all again for attending, and I hope that you have a great Wednesday.